This PowerPoint will discuss the assessment of the respiratory system from Chapter 12. The assessment of the respiratory system is the same as the assessment of any other system. First start with history taking, then go to physical assessment, which is inspection, palpation, percussion, and auscultation, and finally diagnostic tests, labs, and procedures. You could start out with your history taking, looking at the upper respiratory system and then the lower respiratory system. Upper respiratory tract questions: do you have a headache or sinus tenderness, runny nose, postnasal drip? These things could indicate sinusitis, either of the allergic kind or perhaps an infection. Nosebleeds are something that could be a symptom of other things that have nothing to do with respiratory disease. For instance, are they taking coagulation modifiers? Maybe their INR's too high. Nasal meds, such as inhaled corticosteroids like Flonase, can predispose you to nosebleeds. And there are other reasons why your nose bleeds too. Has your voice changed? Could be allergies, could be postnasal drip, could be a vocal cord nodule, could also be laryngeal cancer. That's one of the big symptoms to watch out for with laryngeal cancer. Another thing that is little known, a cause of hoarseness and voice change, is acid reflux. And so, again, sometimes symptoms in the upper respiratory system have nothing to do with respiratory issues. If you think about the lower respiratory tract, do you ever feel short of breath? And the thing about dyspnea is you have to differentiate between dyspnea at rest and dyspnea on exertion. Dyspnea on exertion is one thing. Dyspnea at rest is a completely different thing, and you've got to ask those questions. Could be a respiratory problem, could be a cardiac problem. Do you have a cough? Describe the cough. Is it productive? What does the sputum look like? So a cough, it can indicate either some sort of an irritation or the presence of secretions. If you have secretions present, color is a big deal because different colors of sputum can indicate different things. People will often have this hacking cough and get all kinds of antibiotics and cough syrups and all kinds of stuff, only to find out it's an allergy. And so not all cough necessarily is an infection. Have you experienced night sweats, fever, or chills? These are symptoms of TB, and these are really important to follow up on. Do you ever feel confused, lightheaded, restless, dizzy? This could indicate somebody with hypoxemia, and then of course if you ask them about chest surgeries, this may lead you to something that they haven't talked about yet. Moving on with health history taking, you could ask about exposures. Allergies are a big part of everyday respiratory problems. Do you have respiratory symptoms from allergies, and if so, how do you treat them? They could be taking over-the-counter medications that can interact with other medications, especially decongestants and antihypertensives. So those are some important things to think about. Do you smoke? Because smoking can aggravate or cause many respiratory problems. And of course, then the question is how many packs per day for how many years? So if you're going to document smoking history in pack years, it's the number of packs per day times the number of years equals the number of pack years. So for instance, if I smoked 2 packs per day for 20 years, that would be 2 times 20 or 40 pack years. There are environmental things that can cause respiratory problems. People who work in an industry where they're exposed to asbestos, coal dust, radon, all kinds of chemicals, pesticides, these things can cause lung disease as well. You might want to talk about medications or inhalers that they use at home. Are they treating themselves with something that's been prescribed for them, or are they treating themselves with over-the-counter things? Do you use oxygen or other respiratory treatments? This is really important because if somebody is using oxygen at home, that can give you a clue as to the severity of the disease and the treatment. And then family history. So do any of your relatives have problems such as asthma, emphysema, or TB? So asthma can be allergic, and if so, if you have an allergic tendency, or a genetic component to be predisposed to allergies in your family, that could be assumed. Emphysema, there is a genetic kind of emphysema called alpha antitrypsin emphysema, and so people who don't smoke and who have emphysema very early on in life, that's a genetic thing. Also, TB is contagious, and so if their primary relatives have TB, that's also something you should know about. Moving to objective data collection or physical assessment, we're going to talk about a lot of these things in subsequent slides, but there are just a few I want to discuss here. So if you're looking at a respiratory rate, a depression in respiratory rate could be from drugs, and so it would be good to see what they took, or an elevated respiratory rate could mean respiratory distress, or it could just mean they're having an anxiety attack. So it's important to differentiate that. Also, moving down to neurologic, people who are confused, it could be hypoxemia. And so sometimes if you've got somebody who's in the hospital, let's say with pneumonia, and all of a sudden they're really confused, perhaps their oxygen is off, they're wearing it in their hair instead of in their nose. Lots of different reasons why hypoxemia can cause confusion. And then finally, GI weight loss. You know, you don't always think about respiratory problems with weight loss, but if you have chronic lung disease, there is a really big increased work in breathing. And dyspnea interferes with eating. It's hard to eat when you're really short of breath at rest. And so you're using increased calories because of the increased work of breathing, and you are less likely to be taking in as many calories because of the dyspnea. So, and also coughing, and you know, your mouth just doesn't taste good if you have sputum in it all the time. So weight loss can be a big problem here, and working with them to develop some high calorie, especially high fat diet so that they can get enough calories is really important. So inspecting the skin and nails, skin color is really important, either pallor or blueness, cyanosis. Sometimes you'll see cyanosis around the mouth. That's called circummoral cyanosis. Sometimes you'll see it in the nail beds. So nail color, nail shape is important. There's a picture here about clubbing, and people don't have clubbed nails unless they've been hypoxemic for a long time. So that's a sign of really chronic lung disease. Also mucous membrane color and moisture. Are their mucous membranes pale? Are they blue? Are they pink? Are they moist? Do they have a runny nose? All important things to think about when you're assessing the respiratory system. Respiratory rate is important, but also depth and rhythm are important. Whether a person breathes shallowly or if they can take deep breaths, that tells you a lot. And the rhythm at which they are breathing. Tachypnea is a very fast rhythm. Bradypnea is a slow rhythm, but it's a regular rhythm, and that's different than some of the other things we're going to talk about. Kussmaul's respirations are very rapid, deep respirations, no expiratory pause. They just breathe and breathe and breathe, and this is often seen in metabolic acidosis, such as diabetic ketoacidosis, and also in a coma. Biot's breathing is fast, deep, irregular respirations, and there are a period of apnea in between. And you see this in people with increased intracranial pressure if they have head injuries. Cheyne-Stokes respirations, it's waxing and waning, so they become faster and deeper, and then they become slower and shallower. This is seen in patients who are in a coma, or if sometimes at the end of their life, people who have disorders affecting the central nervous system. This is not a good breathing pattern for sure. The other thing is dyspnea. We talked about that a little bit. Make sure you're looking at whether or not the person has dyspnea with activity or with rest. They may tell you one thing, but what you observe, it may be another thing. They may not realize they're dyspneic at rest, but if you watch them, they may be, and that's really important. Inspecting the nose and mouth is important here. Looking at nasal symptoms such as itchy nose, runny nose, sneezing. Is there any swelling inside the nose? Any abnormalities like polyps? If you look in the mouth, you're looking for a red sore throat, swollen tonsils, perhaps tonsils with an exudate. Those things are all important, and sometimes you can see postnasal drip in the back of someone's throat as well. Inspection of the thorax for chest shape and symmetry is important. Not just is the chest shape symmetric, but is their breathing symmetric? Remember how we talked about that in physical assessment class. Also, are they having retractions? Are they working to breathe so hard that they're using their accessory muscles? That's important too. There's a picture here of a barrel chest versus a normal chest in someone that has chronic obstructive pulmonary disease. That is often an abnormal finding here. I'd like to talk a little bit more about sputum. Characteristics of sputum, the color and tenacity are very important and give you a lot of clues to what's going on with a person. So thick, very tenacious, ropey sputum that's difficult to cough up comes in people who have chronic bronchitis or emphysema. People who have scant amounts, really sticky, kind of rusty colored sputum can be pneumococcal pneumonia. Very frothy, pinkish blood-tinged sputum comes as a result of pulmonary edema, and quite often people are in a great deal of respiratory distress with this. And then there's the yellow, yellow-green, gray-yellow, sometimes brown color. It smells bad and tastes bad, can be a pulmonary infection such as a pneumonia or something else. So really getting them to tell you what their sputum's like is important, but also seeing it makes a big difference too. And then you know for sure that what they're telling you is accurate. More information about sputum here. Any kind of blood-tinged, bloody, or blood-streaked sputum, you can think TB, you could think an ulcerated pulmonary vessel, or even some sort of cancer. If you have really large amounts of sputum, often it'll be an infection like pneumonia or bronchitis. Asthma has a very scanty, white, thin sputum, and very thick and viscous sputum means the person doesn't have adequate hydration. And so if you have somebody who's trying to cough stuff up and it's just really thick and not coming up, improving their hydration will help a lot in that regard. Moving on to palpation and percussion. Palpation, of course, you're going to want to palpate their frontal and maxillary sinuses and ask them if they're having pain. Palpate their lymph nodes. All of the ones around the head and neck are important. look for respiratory excursion and see whether or not their chest is expanding equally. And then sometimes you can feel for crepitus, a crunchy sound that may indicate subcutaneous emphysema. Percussion is something that I don't expect you to know about very much or to do, but just know that resonant percussion sounds are normal, and anything that's dull in the lung is not abnormal. A resonant sound over air is what you get, but if you have a dull one, then that means there's some sort of fluid or consolidation or a mass there. Auscultation of lung sounds is something that's very important for you to know how to do and to do well. This slide goes through all of the different kinds of normal lung sounds, and for my purposes, I could really care less. A normal lung sound is a normal lung sound, and as long as you know that, that's fine with me. This is an illustration from your book about how to listen to lung sounds, all the different places that you need to auscultate. You'll notice that they're auscultating at the apices because remember the apex of the lung is above the clavicle. The other thing you'll notice is that they're not listening over bones and they're not listening over breast tissue. That's very important. This slide goes through adventitious breath sounds. Crackles happen when there is fluid in your airways. It is a discontinuous sound, a bubbling sound. If you take your hair and crinkle it in between your fingers next to your ear, that is sort of like the sound. You find this when there is fluid in the airways, such as in pulmonary edema, sometimes in bronchitis, and in pneumonia. Really fine crackles are when alveoli are popping open on inspiration. It sort of sounds like Velcro being torn apart, and it's heard at the very end of expiration. You hear this in heart failure, in atelectasis, sometimes post-operatively, when you've got some hypostatic stuff going on in your lungs. Wheezes come from narrowed or blocked airways. They are very high-pitched, almost a musical sound, and it's a continuous sound. Mostly you'll hear it on expiration, but it can be also on inspiration, and it is very, very common in asthma. Stridor is an airway obstruction. It is a loud, crowing, in my opinion, scary noise that you can hear without a stethoscope. You can hear this across the room sometimes. It usually is caused from an obstruction from a foreign body if somebody has aspirated something, or a child with croup who has edema. A pleural friction rub is when you have inflamed pleura rubbing together. So remember, you've got two pleural membranes, one that adheres to the lungs and one around the lungs, and there's a very thin space in between them where the pleural fluid is, and if this space gets inflamed, they rub together like sandpaper. It's sort of a sound, a grating sound, the sound of leather rubbing together. It can be heard in pleurisy, can be heard in lung cancer, sometimes in pneumonia. Diminished breath sounds is when there is decreased air movement. It's very faint, they're hard to hear, they sound distant or far away. Sometimes you hear this in emphysema when they don't move very much air, in hypoventilation, and often when people are obese, they have hypoventilation. They don't move very much air, so you don't hear it, or it's hard to hear because they're so large. Absent breath sounds no air movement. No sounds are heard, you hear nothing. If somebody has had a pneumonectomy and they don't have a lung, clearly you're not going to hear breath sounds. The other reason that you would not hear breath sounds would be a pneumothorax. There are many lab tests that are important for people who want to assess the respiratory system. A complete blood count, a CBC, is important. Red blood cells can be low, as in anemia, and if you recall, oxygenation to the tissues is part of 3 different systems: the respiratory system, the hematologic system, and the cardiovascular system. So if you're anemic, the other 2 systems have to work harder. It can also be increased in people who have a chronically low oxygen level. So people who have emphysema, COPD, will have polycythemia, an increased number of red blood cells. White blood cells, of course, an increase in those can indicate infection. A decrease in those can indicate immunosuppression, which increases your chance for respiratory infections. Platelets, of course, have to do with clotting, and that can be important if you have somebody who's got either a nosebleed or is coughing up bloody sputum, and perhaps they are on a coagulation modifier. Arterial blood gases can tell you about the pH. They can tell you about the amount of oxygen and the amount of carbon dioxide present. And then there's a test called the D-dimer, which indicates presence of clots in the body. So if you have somebody who all of a sudden has some chest pain and is very short of breath, they'll draw that to see if there's a risk for pulmonary embolus. Cultures are very important to look at infections. So sputum cultures, you really want them to take deep breaths and to cough the sputum up into a sterile container. Really try hard not to just get saliva, because saliva doesn't get it. You want the sputum. And you need to have them cough several times, because the first cough mobilizes the sputum, and then the second and third coughs often bring the sputum up. It's best to get this first thing in the morning, because secretions build up during the night and it's easier to cough them out if you've got a lot of them there. Fluids can help. Humidification can help. Nebulizers. RT will have something that they call a sputum trap, that they can get a sample if you can't get them to cough something up. A throat culture is something that you may be asked to do. You don't want to touch the inside of the mouth with the swab. You want to get all the way back to their throat. Please warn them about a gag reflex. This is not very comfortable. A nasal swab is something you may also be asked to test or to use, and they use this as a rapid influenza test in the first few days of having symptoms. Oxygen saturation. You know, of course, that you can measure it with a finger probe. You can measure it at rest. You can use it to measure desaturation with exercise. So to put it on somebody during a 6-minute walk, have them walk up and down the hall and see if their saturations drop with exercise. You can also have them wear it while they sleep for a nocturnal oximetry to see if their oxygenation drops when they're asleep. It can be inaccurate if you have low blood flow or decreased perfusion. So in somebody with peripheral vascular disease and really cold fingers, or somebody who's in shock who doesn't have good perfusion, that finger probe isn't going to work very well. If someone has been in a situation where they've had smoke inhalation or carbon monoxide poisoning, that's not going to work very well either, because you may recall that carbon monoxyhemoglobin, the carbon monoxide hemoglobin has a really high affinity for that, and so O2 does not get to bind to the hemoglobin, and so you'll it just doesn't work with the oxygen saturation finger probe. Also, acrylic nails, it doesn't work, and so no matter what number you get, you always want to correlate that with your assessment and make sure it matches what you're seeing. Capnography measures end tidal CO2. There's a special sensor that's on either an ET tube or a nasal prongs, and that's something that's important a little bit more with a critical care patient, maybe a PACU patient, but what they're looking for is a rise in end tidal CO2, and you'll see that as an early sign of sepsis. Some other diagnostic tests that we'll talk about are pulmonary function tests. I've got a couple of slides in a minute here that talk specifically about them and about peak flow meters. A chest x-ray or a chest CT can be important when you're looking for something like a pneumonia or an abscess or pulmonary edema, something like that. And lung masses too will show up there. Bronchoscopy, we'll talk about that a little bit later on another slide. VQ scan. So VQ scan stands for ventilation and perfusion, and they look at this when they're looking for somebody who may have a pulmonary embolus. They want to see if an area is ventilated but not perfused. And so what they do is they inject and inhale a radiopaque substance and then take x-rays that show where the radiopaque air is going and where the radiopaque blood is going. And that if there's a mismatch, then that may mean there's a clot preventing perfusion in some portion of the lung. Angiography is when there's radiopaque dye injected, and you can look at the pulmonary vasculature in that way. You can also find clots that way. And then, of course, there's always a lung biopsy. Sometimes that is done via bronchoscopy, which we'll talk about in a bit. Sometimes it is done through a needle aspiration. Very rarely is it ever done in an open lung situation, unless there's no other way to get to it. The 6-minute walk test is a very simple test that can be done with almost no special equipment or training on the part of the person who is administering the test, usually done in outpatient settings. It is a test that is used to assess submaximal level of functional activity, which means that it's not the absolute most activity that you can do. So they don't push them as hard as they can possibly push them. This works because most activities of daily living are performed at a submaximal level, and this test then can reflect functional exercise level for most daily physical activities that a person will undertake. So basically, it's a test that requires a hallway and no special equipment, no advanced training. And what you do is you measure the distance the patient can walk on a flat, hard surface for a period of 6 minutes. They do this usually before the initiation of therapy of some sort, either medication or a pulmonary rehab exercise program, and then they repeat it over time to determine whether the therapy, either the medication or the exercise, is effective and actually improving their functional exercise capacity. The people walk at their own pace. They can stop and rest at any time, but they need to remain standing. The tester has specific statements that they say along the way to encourage them. They're standardized statements so that you don't introduce any kind of bias. And the patients are encouraged to stop if they have chest pain or any other
really, really bad shortness of breath or whatever, but otherwise just to stop and rest and then continue walking for the 6 minutes if they possibly can. Most people are able to do this just fine with very little instruction and very little prompting. They then at the end of the test rate their dyspnea level, and if they have supplemental oxygen that they use at home, they can use that. They can use their usual mobility aids if they use a cane or a walker or whatever. Some people do this with oximetry during the test. Some people do it without oximetry during the test, and they measure the pulse ox and vital signs before and after. So again, real simple test that almost anybody can do and has really good value for evaluating the efficacy of therapy.
A pulmonary function test, or a PFT, usually includes 3 different tests. There's a spirometry, a DLCO, which is diffusing capacity, and lung volumes. The lady that you see in this picture is sitting in a body box, and that is used to determine lung volumes. The 25-cent word for that is plethysmography. It's kind of a weird, I've had it done before, it's kind of weird to sit in there and breathe. But anyway, that's how they measure the volume of air that's in your lungs. People who do pulmonary function tests will wear a nose clip so that all exhaled air goes into the mouthpiece, that none of it sneaks out their nose, because that part couldn't be measured. Most of these tests are effort dependent, especially the spirometry. So coaching is important, and the person that you're testing has to be able to follow directions. So if there's a language barrier, if there's a hearing disability, or if the person has a cognitive disability, it's really hard to do PFTs on them because they just can't respond to the coaching. Spirometry and lung volumes can tell you a lot about the amount of air that you can get in and out of your lungs. So if you look at this picture, the first piece of it in red looks at different lung volumes. So your tidal volume is normal breathing, and that is about 500 mils, give or take. And then you'll go up to maximum inspiration, which is a big deep breath, biggest deep breath you can take. And then when they blow out forcefully and they blow out as much air as they can possibly blow out, that is known as the expiratory reserve volume. You'll notice that below that is the residual volume. You can never ever blow out all of the air in your lungs, otherwise your lungs would collapse. So even if you expire as much as you think you possibly can, your lungs are never empty. Why is this important? Well, if you have people who have COPD, their lungs get very stiff, they don't move very much air, and their residual volume becomes very large, which means there's a whole lot of stale old air in there, and they're not able to inhale any of the new fresh air that has more oxygen in it. So that's an important thing to measure in those people. And then there's all those other values, values that are there too. The thing with spirometry is you have them breathe in a very deep breath, and then you have them force air out as hard and fast as they can. So it's a big deep breath and then a really, really, really fast, hard exhalation. And what that tells you is that tells you at their FEV, their forced expiratory volume, and that tells you how much air they can get out quickly. If you're normal, you can get a lot of air out quickly. If you have an obstruction of some kind, you don't get very much air out very fast. So that's a real important measure. It has a lot to do with bronchoconstriction. And so if you measure that and then you give somebody a bronchodilator like albuterol, and you measure it again in about 10 or 15 minutes after the albuterol's had time to work, those airways will open up and your FEV1 will improve. And so then that will tell you whether or not your airways are responsive to bronchodilators. That is usually the case in asthma, sometimes the case in COPD, but not always. And so that's important to know, because why do you give people bronchodilators if they're not going to work? It's just doesn't make any sense. So these tests will tell you a lot about a lot of different things and a lot of different people. They're really easy to do. They're non-invasive. You can do a set of PFTs in about 15 minutes. And it'll give you a lot of really good information. The one that I don't have a graph on is DLCO, the diffusing capacity. And what that is you breathe in carbon monoxide, because remember I said carbon monoxide is really grabs onto hemoglobin fast. And so it measures the diffusing capacity of your lungs that way with the carbon monoxide that's marked. So that will give you a good information about how well they're able to oxygenate their lungs. And that's a problem in people who have pulmonary fibrosis and sarcoid and things like that that destroy their lung tissue. A peak flow meter is something that often gets mixed up with an incentive spirometer. If you recall, an incentive spirometer is something that you inhale with, and they're looking to see the amount of air you are inhaling, the tidal volume of air you are inhaling. A peak flow meter has to do with the amount of air that you are exhaling, much like I talked about with the spirometry, your forced expiratory volume. And so it is, as I mentioned, an indirect measure of bronchospasm, because if you are tight, you're not able to exhale as much air as quickly. And this is a fabulous little tool. It's really cheap, it's really easy to use, and people with asthma can use this to monitor changes in their flow, and your peak flows can change before you even know you're having symptoms. And so teaching people how to use this and encouraging them to use it on a regular basis can make a big difference in their ability to control their asthma. Bronchoscopy is a diagnostic tool that is used to examine the inside of the lungs. It has its limits because it can't go into the lung tissue, but it can go down pretty far into the airways. So it's a flexible endoscope that is used to examine the larynx, the trachea, and the bronchial tree. It's used diagnostically for visualization and also to obtain specimens. They either have a little snipper and they'll take a biopsy, or they will wash some saline down there and then suck the saline back up, and they'll have cells present in the washings. They call that bronchoalveolar lavage. It can also be used therapeutically to remove obstructions, foreign bodies, or mucus plugs. The person is conscious during the procedure, but they have conscious sedation. So they are sedated and usually don't remember the procedure. Post-procedure is really important to monitor vital signs and to keep them NPO until their gag reflex returns.